Welcome everyone. In these upcoming few moments, let me introduce you the progress of my PhD and finding answers for questions in chemotherapeutic toxicity. So my name is Dóra Koch. I'm from the second department of pediatrics, and my vision is to achieve the best therapeutic response with the lowest possible toxicity when using chemos, and therefore, we would like to prevent toxicity of chemotherapeutic agents in pediatric care, especially in pediatric malignancies. So first of all, we went through the literature and analyzed the data in connection with a frequently used chemo called vincristine and its administration routes. And after that, we decided to create our own study comparing the pharmacokinetic parameters and toxicities in connection with the dosing schedules of this drug. So let me introduce you my first project. So vincristine is a widely used chemo, and it is one of the most effective chemotherapeutic agents in anti-leukemia care or anti-cancer care. And we have to note, which is really important, that when a child or when patients get the diagnosis of cancer, they have to struggle with this whole thing which comes with it. And not only the diagnosis, but the treatment has a really great impact on their quality of life. So therefore, we are choosing this to analyze. And we know that vincristine has a really specific adverse effect, which is neurotoxicity. And for other drugs, we found and we knew that changing the route of administration or the dosing schedule resulted in decreased toxicity. So we aimed to compare the administration routes in connection with this drug too. So our clinical question was that does the continuous dosing schedule form reduce the severity of adverse events in the case of vincristine? We examined this question in people in oncological care. We compared the continuous infusion with the push injection form, and we investigated the vincristine-induced neurotoxicity, the severity, and also the incidence and prevalence of this outcome. This was the search query we used during our systematic search, and this was the selection process during the selection. This is our first result in connection with the overall neurotoxicity and the pooled prevalences of the overall neurotoxicity and the different administration groups. You can see that it was 37% in the continuous group and 39% in the push group. We investigated the prevalence of severe neurotoxicity, which was 3% in the continuous group and 6% in the push group. We investigated the effect of concomitant medications as well, and regarding to severe neurotoxicity, we found that if vincristine is co-administered with azoles, the overall prevalence of severe neurotoxicity is 32%, and we compared it with the severe prevalence in the push group and with the prevalences or the proportions of the other concomitantly administered medications. And we found this, that the azole co-administration has a significant effect on severe vincristine neurotoxicity. Here you can see paresthesia in different types of malignancies. This is the most prevalent or clinical symptom in sensory vincristine neuropathy. Here you can see that in hematologic malignancies, the rate of paresthesia was almost double as high as in, solid malignancies. Yes, I just want to highlight this. And this is a really debating question in oncological care, that what are the drug interactions or the effects of the concomitantly administered chemos. And we found that bortezomib has, when vincristine was administered with bortezomib, the prevalence was higher than in other cases. It was 57%. So, to summarize this, we can say that this is the first analysis which provides you prevalences in connection with VIPM with a statistical background. And we had a high number of eligible articles, so a lot of subgroup analysis could be performed also in debating topics. And we can highlight the importance of the azole co-administration. And unfortunately, we didn't find any, only one comparative study was available in the literature, so we had to extract data from all the possible articles in which vincristine was administered and neurotoxicity was evaluated. So we can conclude that there is no clear evidence in connection with the administration routes, but in paresthesia we could see a tendency between hematologic and solid malignancies, and we can highlight the significant effect of azole co-administration. And we investigated, as I already mentioned, the effect of concomitant chemos, and we found a tendency in connection with bortezomib, but no other effects of the other concomitant chemos. So we have a hope that modifying the dosing schedule reduces the toxicity. And for example, in the case of etoposide, it is presumed that it potentiates the vincristine-induced neuropathy, but we found that it is safe to administer it concomitantly with vincristine. And in connection with azoles, there are guidelines which says how to administer azoles with vincristine, but these guidelines need revision because severe neurotoxicity, the prevalence of severe neurotoxicity is still high. And we have to find a sensitive patient-friendly method for patient assessment and a precise and objective method for research and for reporting incidence of VIPN or severity. And we have a strong need for protocoled randomized controlled trials. This is the status of the manuscript. And as I've already said, there is a strong need for protocoled randomized controlled trials in this topic. So we started one, which I want to highlight from here that it could be a gap-filling information in connection with the administration of this frequently used chemo. In our study, we want to compare the routes of administrations, the toxicity levels, and we want to correlate it with the observed pharmacokinetic parameters, because in the study there will be a pharmacokinetic measurement as well. So it will be a two-armed clinical trial in which vincristine will be administered in 3-hour-long infusion and in the conventional push injection form. These are the days of the protocol in the induction therapy where vincristine is administered. These are the days of the pharmacokinetic sample collection and measurement, and these are the days of the neurological assessment times. So our question is that does the continuous administration form reduce the toxicity? The question will be investigated in children with hematologic malignancies. We will compare these two dosing schedules, and the VIPN will be the primary investigated outcome. Our hypothesis is that it reduces the severity, and the implication will be the decrease in toxicity. The tools used to evaluate toxicity will be the very well-known CTCA grading system, also nerve conduction studies and questionnaires. And there are some secondary outcomes in connection with other organ toxicities and hematologic toxicity and therapeutic response. We wrote a protocol using the SPIRIT guideline, but we had to start a pilot because of the sample size calculation for creating a reproducible protocol for our study. This is just a quick summary in connection with my two ongoing projects, and thank you very much for your attention. And tough times never last, but tough people do. Thank you very much for your attention.
What's up with the pilot study? How many patients do you have, and what are your experiences with that part?
It's hard to say any experiences yet. We have 10 included patients already. We already assessed the neurotoxicity through questionnaires and the CTCA grading system. And unfortunately, we couldn't perform nerve conduction studies in all of our patients. But in the protocol for the first, we want to analyze neurotoxicity just by the CTCA grading system. And it's hard to say anything preliminary from 10 patients, but we hope that if you see the patients, we can see that during the induction therapy, the 3-hour group seems to do better, or I don't know how to say it, but they seem better for me.
Okay. And what is the hardest part for you organizing this clinical trial, or performing the study part?
For me, the hardest part is to schedule the neurological examination. So find the human resources for that, who does that, and yes, so the scheduling part is, but when I'm going to start work there from September, and maybe I hope that it will be easier if I spend my whole time there, and they know me, so hopefully it will be easier from September.
Would you like to launch an international, run an international study? Or just keep it a national, for the second topic, right?
Yes. Now we are running just in 2 centers here in Hungary, and we will see our results after the pilot, and after that maybe we can do it internationally as well.
How did they look at the neurotoxicity? What was the measurement type? And also, how did they grade the severity of toxicity?
Thank you very much for your question. So, the assessment of neurotoxicity is really heterogeneous. We have a lot of tools. Most of the studies use the CTCAE grading system, which also evaluates the incidence of neurotoxicity and the severity on a 5. So yes, the severity. And there are questionnaires as well, and for example, nerve conduction studies, etc. So the assessment is really heterogeneous, and we include it all in our study. So, for example, there were assessment methods, questionnaires, and there was a score, for example, from if you were above a score, it was considered neuropathy. If you were below, it wasn't. And it is much more different than, for example, the CTCA grading system. So, yes, it's really heterogeneous. This is my answer for your question.
You mentioned that a patient-friendly method is needed for practice to measure the severity or the level of neurotoxicity. What do you mean by that? What could be this method, this patient-friendly method?
Thank you very much. It's a great question, especially in pediatric care, because we have really specific tools to assess neuropathy, for example, nerve conduction studies, but as you know, it's not that patient-friendly because it hurts, kind of hurts. And we have questionnaires, but they are not specific, and it can be used only above 6 years older, in children 6 years older. So these are patients. So the real problem is not if a method is patient-friendly or not, is maybe the specificity, because we have patient-friendly methods already, but they are not specific enough to assess vincristine-induced neuropathy.